Assalamu alaikum all. We are very happy about to being here and sharing our experience to all. So before start, I would also like to thank you to Brilliant company. So when we are using implants, you know that for instance in Turkey more than 400 different brands, implant brands in Turkey, but what's the difference? The difference is like Brilliant investing education to our colleagues and not only being producing the material but also investing the education of the patients. That's why we are here, and I would also particularly thank you, Mr. Brahim, for this approach of his company.
Me too.
Okay.
I would like to thank also to Brilliant Company and also to my dear friend Igor Osman for inviting us to present before you. This is our first time in Jordan, and I don't think it will be the last time. We will come many times here. It's not very far from our home country. It's just 2.5 hours of flight. And as far as I see from this morning, it's a beautiful country. I like to make presentation with a lot of technologic aid. And today I want to make it through my iPad mini. If I have some problem, please forgive me. It's because of my stubborn character of using technology.
Okay, before start, I would like to present ourselves. We are working together with Selim, long time. We were also together a long time at the university, but he retired before than me. Now we are sharing the same office with my brother. P is Mr. Pamuk. G is to Gökbuget.
G, Aslan,
so
and the other G
our
is
clinic.
Aslan's
We have
brother.
also one periodontist in our office, and the others are our assistants, assisting us during our work. We do believe, Selim and myself, very much team approach, multidisciplinary approach of the caring of our patients.
We will do our presentation through these steps: introduction, analysis of available systems, workflow for guided surgery, case presentations, and conclusion remarks. We have limited time, just 45 minutes, and in this time period, it's quite difficult to go into details. So we will give you an overview of the guided implant surgery, and thankfully, this morning, Dr. Stepanovic gave us a lot of insights of the system. Computerized dentistry, computerized implantology used more and more in daily practice, daily implant practice nowadays. This is because to improve the accuracy of implant placement and also to have a predictable results before starting surgery.
Okay, I am a periodontist and my colleague Selim is a prosthodontist, so we are working together. First of all, I would like to ask you a question. What do we like to do in our office? For post-op, during the surgery, we would like to give the best function, aesthetic and phonetics, and we would like to give as much as less post-operatively antibiotics, analgesics, and the other things. So that's why when we think about doing implants, this minimal invasive approaches with guided surgeries, I thought, ideal approach for the implant dentistries. So the preoperative planning is one of the most important part of this computer-guided approaches, because we should carefully evaluate the patients first, the medical history, examination, patient's individual features, tooths, expectations. Comprehensively, you need to examine your patient before doing the surgery itself.
So at that time, at the beginning of the implantology, let's say, we were not placing the implants as today. At that time, implants were placed at the residual, the site where we will find a bone, residual bone. So that means at that time we were not able to predict the results. The idea was function. Imagine when the Brånemark placed first implants, they were placed always edentulous mouth just to support the prosthesis. And think about the prosthesis they were placed at that time. Nowadays, you cannot accept, for instance, me, if I need to have implants, I would not accept that kind of prosthesis now. So the aesthetics became more important in time. So use of guided surgery and, let's say, backward planning, we will come later on. We need to first plan the prosthesis and then try to the right place, right bony site to place our implants. So at that time we may say that the angulation and the implant sites were dictated by the residual bone. Now we are doing prosthetically driven implantology. Therefore, our planning should match the conclusion. If we talk like the computer science, or if we need to make an analogy with the computer science, you know, at the beginning of the Macintosh computer, they were saying what you see is what you get. Now in implantology, what can we say? What we get, or what you get, our patient will get, is what we plan. Despite significant advances in devices and technology, we are still placing dental implants. We cannot, let's say, place implants manually or without any guide to the correct angulation, to the correct place. It's not easy to do this. It's a challenge.
Okay. Before we started to 3D planning, what were we are doing before we don't have a computerized planning system? We were diagnostic casts, and we were doing some probing depth. We are planning on panoramic radiographs. So in the past, this is our very old slides before the computerized technology. We were making an incision, opening the crystal wall, and we were calculating the bone width. And before you calculate it, you should also take into consideration the soft tissue thickness. We were obtaining some plaster models, and calculating the soft tissue thickness and putting some amount of diameter implants and trying to calculate the correct bone volume at that time. Or in the patient mouse, we were marking some certain areas and we were calculating the bone width with the 3 points and estimating our implant diameter. So we actually had a long time on the work on this type of work. You see, there was some metal balls before the X-ray taking. We were preparing this kind of devices before taking the panoramic X-rays. Then we were calculating the bone height from the alveolar nerve to the crystal. So it was quite tough times for us. You see, this is our very typical one. These are the implants where we are planning to put, and tooth numbers, the height, but we don't have any idea about the width of the bone. So it was kind of a blind type of work at that time. So then, thanks God, now we have this 3D devices, cone beam CT scans, so we can able to plan our implants position, diameter, and we have frontal, horizontal, sagittal sections, and you can see one-to-one measuring. We can put the implants in the place, and we can arrange the implant axis. If you don't like the diameter of implant, you can go to the library and you can change. And you can put also the abutments, and you can calculate the position and all the implants positioning with the prosthetic guides.
You know, I'm a prosthodontist. I do not place implants. For this, I have a hitman. This is the hitman. He places the implants. I tell him to place the implants. He does. So as a prosthodontist, our expectations from implantology is always a predictable prosthesis, a support for a predictable prosthesis. We don't like surprises. If we get surprises, they do not deal with this. We do deal with these surprises. So I don't like those kind of things. So this led to the development of prosthetically driven implantology. And with the aid of this computer guides, 3D scannings, volumetric tomographies, and planning the prosthesis before starting the implant placement, we now have predictable results. So we can call it, as I told before, backward planning. That means we plan before the prosthesis, and then we look for the necessary implants, the number, the location, angulation, and then we do the surgery. It's not like I will place the implants and then I have 3 months or 4 months. I can think and place the prosthesis afterwards. We'll see. God will help me. No, it's not possible anymore. So to achieve these objectives, we use templates or surgical guides. These templates or these surgical guides is a kind of a link between diagnostic and the surgery. On the other hand, up to now it is called surgical guide, right? Everybody calls it surgical. Why it is surgical guide? Because it is used during the surgery. But why do we use this surgical guide or this guide? Because we want to have a predictable prosthesis. Why don't we call it prosthetic guide. It will help us to make a predictable prosthesis, right? Isn't it? So, I always say, instead of surgical guide, I say prosthetic guide, not surgical guide. Maybe it's because of my prosthetic ego. But I tell you, it's a prosthetic guide. None of our patients comes into the office asking you implants. They always ask a prosthesis. And we use to support implants our prosthesis. Isn't it? So, it's not a surgical guide, it's a prosthetic guide.
Okay, when you get your prosthetic guide in your hands, it should be, everything has to be done carefully before treatment plan, your patient's individual features, everything. Because when you get your prosthetic guide in your hand, it means that now you follow that guides, okay? So the other properties of the guide should be stable, should be rigid material, and of limited size, easy to insert, preferably transparent, modifiable, and sterilizable.
So when we use this for single tooth restorations, one of the important aspects of surgical guides is to use with single tooth restoration, especially in the aesthetic zone. If we do a mistakes of, let's say, in placing or drilling of 1 millimeters, either buccally or palatally, majorly or distally, we end up with a big trouble in restoring. If we do this, then you have white hairs like me. I tell you. It's true. So even for a single tooth in anterior region, using the guide is absolutely necessary. The other cases, you know, these are partially edentulous patients, complete edentulous patients.
Basically three types of prosthetic guide. One could be a mucosal supported, the other one is tooth supported or bone supported. Three types of guides available, and we can choose it for the individual cases. So there is a lot of advantages for the patients, of course. For instance, it's all planned in the computer, so you should take into consideration about the anatomic factors, sinus, nervous alveolars, inferior alveolar region, everything. So this procedure enhances the security, planning accuracy, better implant location. So you don't have a surprise because your implant position is prosthetically guided position. You don't have a surprise after that. So of course improve the patient comfort significantly postoperatively. Almost they are using very short period of time painkiller, and the accuracy of fabrication and delivery of fixed prosthesis, and of course due to the prosthetically driven surgery, improved aesthetic and predictable results, and of course predictable costs for the patients. Okay, if we could analyze the available systems, we have a software. Okay, can go on. So.
Why it doesn't? Okay, let's go.
It's volumetric reconstruction and CT or cone beam CTs we have for the planning phase of the procedure.
We get some data from the CT or CBCT, and then we transfer to the software. software analyze this and make a 3D reconstruction, and we do our first implant placement on the software on a computer screen. The accuracy depends on several factors, but three most important factors are thickness of the slices when you get the CT scan. The other one is the moment of the patient during the scanning, and also the artifacts caused by the previous or existing restorations. Some of existing restorations may cause a lot of artifacts, and this may lead, like, you may think that you have more or large bone, but at the end, when you open the flap, you end up with a very thin bone. These kind of things happened to us once, and we were really surprised during the surgery. So, if it is possible, remove all previous crowns and bridges before taking the CBCTs.
Okay, there are many different systems available in the market. There's lots of materialized and novel starts that almost all the different companies have softwares in the market now.
Two systems are available in the market. One is the external production. That means you send your data to a remote place and they prepare the guide and send you back. Or in-house manufacturing. That means you prepare your guide by yourself in your office or in your dental laboratory without sending to a remote place. These are systems requiring external production. Materialized implant, Nobel Biocare, Biomed 3i, Astra, Expertise.
It takes
SKYcat.
8-10 days to come back the surgical or prosthetic guides in your hands.
When we look at the in-house production, we see SKYplanX, Straumanns, and the other companies. With these ones, we can produce our guides by ourselves with the help of this kind of, let's say, tables in our offices.
Okay, let's quickly look workflow for the guided surgery. This is we need, as I told you before, we need to make a clinical exam carefully, take all the informations, the medical history, all the things from the patients, and of course visual examination. Then we can make roughly and panoramic X-ray and look the situation, the anatomic situation, and the periapical lesion or whatever you are looking for. Then determination of the case type, which kind of material use, if the patient's edentulous, partial, or whatever patient needs. Then we should consult our patients. Normally patients come to office then saying that I want implants. They are what they are saying, that, but in fact they need a prosthetic device. And resolution of any clinical and radiographic diagnosis inquiries. Then we use routinely diagnostic wax apps. We are taking impression from the patient and transferring to the articulator and discussing each other what we can do or what we cannot do for the patient.
After that, we need to decide what kind of scanning appliance we're going to use. We can use existing prosthesis if it is stable enough in the mouth, or we can start from the scratch to produce a prosthesis or scanning appliance. After that, After we decide the scanning appliance, we send it either to laboratory or we do it in our dental office. If we use existing prosthesis, we can
Duplicate.
we can do it in our dental office. But if we want to start from the scratch, then we send it to the laboratory. When the scan prosthesis or scanning appliance is ready, we deliver to the patient, and the patient goes to CT scanning. CT scanning is done with the appliance in place, I mean in the mouth. And the radiographic, when the CT scan is done, the laboratory sends us the digital files, and we import these digital files into the software to make or to produce the three-dimensional model in the computer.
So this is the steps of treatment. We are making all final treatment plans with 3D CT scans and models, and resolution of any physical and radiographical diagnostic inquiries, and pre-op patient consultation. We are comprehensively informing the patients what we are doing. This CT scans also helps a lot. When you take your patient on your computer and explain the positioning of implants, what are you planning, and the position, the size and diameters and everything. So it's also very educated for the patients. And it also helps the acceptance of the patients to your treatment plan. Then order the placement.
So the surgical or prosthetic guide is fabricated. We receive this guide from the laboratory or from the remote laboratory, or we do it by ourselves. Then we construct or we produce the implant master model. If we are planning to do immediate loading, we do plaster surgery. I say plaster surgery, and prepare our provisional restoration ready to deliver after the surgery into the mouth of the patient. So the next step is the surgery and also the placement of definitive prosthesis after the healing period, and deciding the patient follow-up maintenance of the restoration, who will continue to maintain or who will continue to follow the patient, the surgeon or the prosthodontist. It will be decided beforehand in order not to make any confusion after the end of the treatment.
Okay, then before the surgery, during the surgery we should decide flap or tissue punch. If versus in the lower jaw, usually it happens if you have a limited amount of keratinized tissue. In general, the edentulous patient always does. So in order to place your implants in keratinized tissue, you can make a small incision and open the bone tissue. Then you can put an implant and put 2 small sutures, for instance, in order to get proper keratinized tissue around your implants. Otherwise, your implants can stay in attached alveolar mucosa, so it causes another procedure. Then guided surgery. When you guided your implants, then abutments in placement of immediate provisional prosthesis immediately after the surgery.
On the software, the first step is the drawing the panoramic curve, and then for precise planning and positioning, the implants are chosen, the diameter and the length, and we place them on the software to the area to the site we want to place implants. Length and diameter are selected. These are according to the bone morphology, according to the proximity to the nerve or the anatomic sites. And we place those implants according to the best biomechanic conditions, force and stress distribution, as well as aesthetics. Aesthetics is also one of the important aspects of guided surgery. At the end, the software will give us some parameters or some coordinates. We print out these coordinates and then we transfer to the machine or to the zero table of the zero level table of the SKYplanX let's say device. Yeah, device. We mount it on this one, and then for each implant we change the inclination and we start drilling the plaster through the guide, and the sleeves are placed and glued, and the guide is ready to use in the mouth.
Yeah. This is our guide for the surgery.
Sometimes patients' existing prosthesis can be used as a scan prosthesis. For this purpose, we can use X-resin flow, which is radio opaque. What we do, we cover the teeth portion of the prosthesis with X-resin flow, and also we spread X-resin flow into the mucosal surface of the existing prosthesis in a thin layer, just to make the, just to differentiate mucosa with the prosthesis and also bone. And then we place this prosthesis, the existing prosthesis, into the mouth of the patient and do the scanning. Another way to produce scan prosthesis, in the case of, let's say, this patient has a partial denture and we cannot use it because of the clasps. So what we do, we first set up teeth in the edentulous area. We make a copy of the setup with a silicone, and we inject 3D resin. We inject 3D resin into this, how can I say, into this silicone mold, cover it with the X resin to produce the scan prosthesis. Now we can proceed with the cases. This is the first one.
Okay,
Aslan will explain.
This is our
the case.
One of our good friends. He's an ENT surgeon. So he has lost his first molar tooth. Then we wait for a while, and we think that he's kind of an ideal patient for this kind of flapless computer-guided surgery. This is the area before surgery. So we prepare all the procedures which we have told already. Then we prepare a guide.
When it is a single tooth case, it's one of the easiest scan prosthesis fabrication. We're using a reference plate. We first take an impression from the mouth of the patient, and we spread kind of a bite registration material over the reference plate. This bite registration material should be very strong, very hard, not flexible. And then we place the model over this bite registration material. This is the end of the scan prosthesis. I mean, the fabrication of the scan prosthesis. With this reference plate and bite registration material, you can send your patient to the CT scan. When you receive the CT scan results, you put this reference plate into the SKYplanX device and start drilling for the guide fabrication. So you use this reference plate with this bite registration material very easily for surgical or prosthetic guide.
This is what we planned, the implant size and diameter. We also planned the abutments in the same software. So this is one of the most important thing is if you are using the these cone beam CT scans, you can take some advantages, some of the anatomic features. For instance, the sinus anatomy sometimes, you know, it's sometimes could be like this. So in order to make some sinus procedure or internal lifting procedure, you can make a small, give a small angulation to your implants, then avoid to go through the sinus. So it's really helps to your procedure.
In that case, we decided to prepare the temporary restoration before the surgery. So during the fabrication of the during the fabrication or drilling the reference plate, we also drill a hole in the plaster. We place an implant analog in it and put the temporary abutments over it, and we fabricated the provisional restoration. I call this procedure plaster surgery, which I like. I don't like blood.
Yeah,
you don't have blood
your
on
technician
plaster.
is
You
doing
just
the
have
surgery
powder.
before you in the lab.
So the case now.
So now we're ready to go. We are putting the our guides into patient's mouth. So we know the diameter of our implants. We know the length of the implants. So we are just choosing the proper drills and going through the hole. It's hard to say a surgery. It's a flapless procedure. Then immediately I finish my job, and Selim comes and takes place and putting the abutments and the temporary
I
crown.
screw the implant, I screw the temporary abutment, I place the temporary crown on it. It's always without occlusal contact. It's a non-functional, let's say, non-functional immediate loading.
Then
After 4 to 5 months, after the healing period, we change the temporary abutment with the titanium abutment, and I made the restoration with CEREC machine, and so I also replaced the amalgam filling with an inlay, ceramic inlay that I made in CEREC. So I like digital dentistry. I like technology. Let's come to a fully edentulous upper jaw.
this system needs, before planning, you need some reference points before sending the patient's cone beam CT scans. So we use 3 mini implants as much as symmetrics. Then we are fabricating a prosthetic guide, then sending patient to the cone beam CT scans. So we use that reference points to make a proper and accurate implant design. So this case is fast and fix procedures. So patient has going to get 4 implants in the upper jaw, 2 in the front side, and 2 tilted abutments, tilted implants on the posterior side, in order to avoid the sinus lift procedures. Then we start the procedure and drilling. Basically, there's a locker here, different color codes. So if the more you go to different diameters, you are changing this part. For instance, this is for 3.5 millimeter implants. This green color. So this is after the surgery.
Yeah, it's right after the placement of the implants.
So as you can see here, the advantages of this system is this is immediately after surgery, before the impression. So you can see obviously that we have very, very limited amount of wound in the mouth before the impression.
I always prefer taking open tray impression. Sometimes I connect the impression copings together with a acrylic resin. Sometimes I'm so lazy to do this, but don't be lazy to do this if you want to be on the safe side.
So please also note that the 4 implants, 2 tilted implants, 2 straight implants, but because of the software planning, what we get is at the end of the surgery, we completely parallel 4 implants. 2 is almost 30 degrees of tilted implants. But you can use 30-35 degrees of abutments in the software, and you can see the parallelism of these implants. Then you can, if you don't get the good parallel implants in software, you can little bit change it, then make it this parallel. This is immediately after surgery. It's exactly what we planned in the computer.
And the temporary prosthesis is fixed according to the fast and fix protocol.
So patient leave the office.
This was the patient's previous or existing restorations converted to a fixed restoration after the implant placement, according to the new situation.
It's post-op panoramics.
It's not post-op, I guess it's...
So you can see,
yeah, after the...
This is the anterior wall of the sinus here, okay? This is exactly what we planned in the computer.
And this is the end result after 4 months. Let's go to a lower jaw case.
In the lower jaw is the same procedure like upper jaw. We put 3 mini implants in order to make a stabilization of the scan prosthesis.
Then I took an impression over the mouth, and we made a setup. We obtained a silicone master, and we pour X-resin into this silicone in order to duplicate the teeth. After setting off the X-resin, we used 3D resin to produce scan prosthesis, as you see here.
Okay, this is patient's scan prosthesis before the cone beam CT scans. Then when you get the final guides, now patient's ready to go for the implants.
Implants are placed again.
Immediately after operation, before the impression.
And the temporary prosthesis in the mouth.
Yeah,
according to the fast and fix protocol. So there are many advantages of the guided surgery. One of them, and also SKYplanX, it's an open system. It's independent of the implant manufacturer. So in the library you have almost every implant system, 75 manufacturers, 2,100 different implants. You don't need to have a license, so there is no license cost, dongle, or pay per patient's fee. It has an automatic nerve detection, so it helps you to avoid some anatomic structures. You can import STL files or export STL files, and you have always online support with NetViewer. There are some advantages for the practitioners. It's an optimal marketing tool. Due to the perfect patient education, you show your patients everything you're going to do. You have an optimal results due to the backward planning. For the forensic purposes, you have the best possible documentation. It's now very important. I don't know if it is the same in your country, but in our country and in Europe, in America, this becomes very, very important. We need to have a written, informed consent from our patient. And this should be way before the surgery, not just before the surgery, like 5 minutes before. It has to be at least 24 hours before the surgery. It's a time-saving procedure because the surgery time is short. You don't have to raise the flap. And the cost-wise, it is predictable. You don't have to make sinus lifting. You don't have to fill the sinus with the bone grafts. And beforehand, you know what kind of abutments you're going to use for end results, so you know every cost beforehand, before starting your surgery.
It's significantly, we have a higher patient satisfaction because they shortened the surgery time, no suturing, and the postoperatively significant less pain, much more quicker healing, and due to the prosthetic part, you don't need to avoid some prosthetic materials go into under your flap or something like that. Significantly less ödem patients got. In general, 99% of patients no ecchymosis, and in general, no suturing after surgery.
Of course, every procedure has mistakes. No procedure has absolute precision. So these are the product, let's say, of the tomographic images. They come because of the fabrication of the surgical guide, because inaccurate positioning of the guide. It may be also because of mechanical errors. It may be also because of the reduced mouth opening, and also because of the human mistakes.
So when you got your prosthetic guide in your hand and put in your patient's mouth, you should really consider that this guide is which you planned before. If you have some doubt when you put in your patient's mouth that the drill hole is, for instance, looks little bit buccal because you are a surgeon, okay? So you can, when you put your drills into the hole, you should also can easily understand that if the hole is that hole which you planned in the computer. So if you have some doubt, you can go back to the computer and make sure that if it is the right place or not.
We come to the conclusion remarks.
So we have this kind of universal guides in the market. Different systems are using this kind of devices. So they are fabricating only one diameter of hole. Then you can reduce the hole's diameter with this kind of devices. Not in the SKYplanX system, but the other systems are using this. And also this system also have some advantages. For instance, if you are using the materializer or Nobel BioCare, you should fix your guide into the patient's mouth with your anchor pins in order to get the stabilization of your guide, which we are not using in bread system. You can also have a bone supported. If you have a limited amount of bone or very unstable soft tissue, you can open it and you can put your guides directly onto the bone and you can use your guide. Sometimes I use it when I have a very limited amount of bone, so I'm sometimes using the open and bone supported guides. We have also tooth supported. This is the most rigid one, most stable one, I can say. The accuracy is better than the others. This is the fixation pins, as you can see here. Sometimes we use screws, but now this very old one. Nowadays I am also using, if I use that system, anchor pins. As I told you before, if you have a problem with the keratinized tissue, so you can, in general we are doing is, I'm making a small incision and taking this keratinized tissue on the buccal side. So I'm putting the guides and drilling, putting implants and putting 2 small sutures there. Then at the end of the healing, I am also getting some amount of keratinized tissue on the buccal side of the tooth, which is very important for the further oral hygiene and the bone resorption around your implants. So you can make a small incision. It's not a big deal. And for our patient, this is an almost excellent treatment alternative for implant insertion, regardless of the surgical technique. Helpful for virtual planning in case of severe bone resorption. So when you have really limited amount of bone, this is one of the best solutions for your patients, because freehand you cannot use the optimal buccal, palatal and vertical dimension of the bone this much accurate. And the success of the guide depends on the accuracy of the all clinical and laboratory steps and virtual planning. Of course, each step is very important, so you should, 7 out of 10 of the part of the thing is planning. So the other 3 is applying in the clinic. Even with some limitation, it is essential for the evaluation for safety and treatment success of implants.
We would like to finish our presentation with a saying of one of our good friends, Scott Gaz. He's one of the pioneers of guided surgery. He says, it's not a scan, it's a plan. It's not a scan, it's a plan. Thank Scott for your quotation.
Thank you.